Hello again, it's Dr. Suchard with a clinical toxicology video corresponding to Chapter 34 in Goldfrank's Toxicologic Emergencies on colchicine, podophyllin, and the Vinca alkaloids. This collection of topics is weird because the chapter is in the section about analgesic and anti-inflammatory drugs, but that only applies to colchicine here. The other drugs seem to be included only because of a shared mechanism of action, since they are used for very different indications. The learning objectives for this video are that you should be able to explain the mechanism of action, and therefore the mechanism of toxicity, for colchicine, podophyllin, and the Vinca alkaloids, and be able to outline the expected clinical effects and time course of colchicine toxicity. The common factor among the agents named in this chapter is that they are all plant-derived inhibitors of normal microtubular function. Colchicine is derived from the autumn crocus, Colchicum autumnale. Podophyllin and related compounds come from the mayapple, Podophyllum peltatum, and the Vinca alkaloids come from the periwinkle plant, Vinca minor. But we're going to be focusing on colchicine. Colchicine exerts its anti-inflammatory effect through inhibiting microtubule assembly in the white blood cells responsible for elaborating an inflammatory response, say as occurs in an acute flare of gouty arthritis. Microtubules are long polymers of alpha and beta tubulin dimers, and they are necessary, among other things, for mitosis and for normal inflammatory leukocyte function. Colchicine gums up the works, impairing microtubule assembly and therefore impairing inflammatory leukocyte function. Podophyllin and the Vinca alkaloids are used for cytotoxic chemotherapy, to kill cells. Podophyllin is used topically to burn off genital warts, and the Vinca alkaloids are used intravenously to treat cancer. And we even see here some labeling as cytotoxic agents and a warning to only use IV instead of intrathecally, directly into the CSF. They are not used therapeutically for anti-inflammatory effect, and we're not going to be mentioning them again. In the United States, colchicine is FDA approved for use primarily in gout, but also for familial Mediterranean fever and some other indications. The photograph here shows a patient with podagra, an acute flare of gouty arthritis in the metatarsal phalangeal joint of the big toe. Gout can occur in any joint, but this joint is the most classic. If the patient takes colchicine, the white cells elaborating inflammation in the joint are poisoned, which will hopefully reduce the redness, pain, and swelling. Now we're going to focus on what happens with colchicine toxicity. Because microtubules are necessary to create the mitotic spindle, colchicine inhibits mitosis and will damage tissues with the most rapidly dividing cells. This especially includes the gastrointestinal mucosa. So with mild colchicine toxicity, we'd expect to see GI side effects like nausea, vomiting, and diarrhea. In fact, there is an old adage about how to use colchicine that seems kind of cruel. You'd tell the patient with a gout flare to take colchicine and repeat doses until they develop diarrhea, because the patients have to develop the runs, diarrhea, before they can walk, because they hurt too much from gout to walk. With more severe colchicine toxicity, other organ systems begin to get affected, including the bone marrow, since it also has a high cell replication rate, and you can get multisystem organ involvement. Colchicine typically comes in 0.6 milligram tablets, and the estimated fatal dose is greater than 0.8 milligrams per kilogram, which is nearly 100 tablets. The classic clinical course seen with colchicine toxicity is divided into 3 phases. Phase 1 starts within just a few hours and lasts for about 24 hours, characterized by GI irritant effects, as already discussed. Patients with more severe overdose then develop Phase 2, days 1 through 7, where they can develop multisystem organ dysfunction. Interestingly, the white blood cell count will initially go up, but will then rapidly decline as bone marrow toxicity sets in. Phase 3 is either recovery or death. Patients can develop long-term myopathy or neuropathy and may lose their hair about 2 to 3 weeks post-overdose. Like for many poisonings, colchicine toxicity is treated with symptomatic and supportive care, since there is no antidote available. Now, the supportive care necessary could be quite intense. Sicker patients may need to be admitted to the ICU, bone marrow stimulating drugs like G-CSF may be indicated if they're leukopenic, hemodialysis if they develop renal failure, intubation and ventilation if they develop adult respiratory distress syndrome, and antibiotics for sepsis. Now, I just said that there's no antidote, but that doesn't mean people aren't looking, because colchicine is a gruesome way to go. Anti-colchicine Fab fragments have been developed and investigated in animal studies, and there's even some limited human experience, but this is experimental only at this time, and there may never be a commercially available product. And on that happy note, we're done. I'll be seeing you around.